All right, good afternoon. Can everyone see this in the slideshow mode? Are you seeing it in slideshow?
Yes.
Yes. Okay, thank you so much. All righty here. So it is exactly 12 o'clock and I do want to get started on time here because we do have a very full agenda in these 2 hours. So welcome everyone to our virtual Lung Committee main meeting. I was just realizing that we haven't had a meeting, of course, due to COVID. The last time was October at the fall 2019. And we have certainly been so productive since that time period. So let me start, first of all, by showing you our agenda. Again, this is just our abbreviated agenda, and this is our traditional agenda menu here. I then, as always, want to welcome all of our new members to the Lung Committee and to the Lung Disease Working Group as well. So we do have several members here, and there are several members that unfortunately didn't get on this list, but they'll be on the next list, and we're happy to have each and every one of you in our great Lung Committee. Okay, as I had mentioned, we have been really busy in the SWOG Lung Committee. In the spring of 2020, I think everybody knows that we did activate in a very short time period 6 trials, and I have starred all of these trials here. So that in and of itself is a huge task, but the harder task is now beginning, and that is we have to accrue to all of these studies. And so I'm going to start with saying, please, everybody open these trials. We, of course, think that these are asking really impactful and important questions. And so I do want to really urge everyone, if you haven't opened these trials, I know with COVID, sometimes opening the trials can be a slower process these days, but please do that. I also show here the landscape. I call this my kind of snapshot of all of the cooperative group trials that the Lung Committee does have in terms of the major trials. And you can see that these spaces are becoming quite full, and that's a good thing. There's a lot of new therapeutics happening in lung cancer. I don't need to tell any of you all of that. So it's really an exciting time to be doing lung cancer research and accruing our patients with our ultimate goal, of course, of advancing therapies for our patients and doing so in a more precise way. We've also been very busy on the publication side as well. We have 7 publications here, but we have 10 manuscripts that are in preparation. We also, because we have had the trials activated in 2020, we have seen this nice increase in our accruals. So that's great, but we want to, we really want to get up here. So with 6 new trials, that would be really fantastic. I always say, even though we have accrual goals, if we can accrue faster than those goals, wow, we would really just be so even more fantastic than we already are. So important to do that. I do want to mention that we do have 2 ASCO abstracts. We have one abstract that is 1900A, and this is rucaparib in patients with high LOH or BRCA1/2 mutations. This is from Dr. Reese and LungMap, and it's going to be a poster discussion. And then Karen Retkamp and her team have a poster on the safety analysis for the pembrolizumab plus ramucirumab versus standard of care. So looking forward to those 2 presentations. And I'm going to turn it over briefly now to our fantastic patient advocate, Judy Johnson, for a few comments.
Thank you, Karen. Could you go to the next slide? Oh, thanks. Okay. So I just wanted to highlight the whole patient advocate community for you all really quickly, because there are 2 types, research and community. And research advocates know the trials. We have a personal connection to cancer. We've been trained and experienced with clinical trial development. and implementation and focus on patient impact. As many of you know, my connection to lung cancer is the loss of my dad and my father-in-law and 5 years of experience as a clinical research coordinator at Washington University in St. Louis. So community advocates know their communities. And as you can see here, we have a number of those represented. Whether it's veterans, older adults, or Latinos with cancer, they know the concerns and prioritize and represent those communities. We have 5 here, and we have just filled the rural and the LGBTQ positions. So research advocates bring the experienced patient eye to trial eligibility and outreach, and community advocates are fresh, frontline, offering a different take on these and other issues within their communities. Okay, next one, please. Next slide. There we go. So I just wanted to give you a couple of things about accrual efforts. It was really exciting that Dr. Daly's study was the first SWOG study to have a patient-focused plain language summary, which is currently under review for central IRB approval. Many thanks to Wendy Lawton, SWOG's prior communications manager, for making this happen. Sadly, Wendy has left SWOG for a new position. Frank DeSanto, who held the position before Wendy, is stepping in on a temporary basis, perhaps permanent, I'm not sure yet. He will continue to support this plain language initiative for our other studies. 2 SWOG studies, Dr. Rusthoven's small cell PCI versus MRI trial and Dr. Al-Jumali's borderline performance status trial, now have a community advocate connection. Bruce Wright, military veterans community advocate, is brainstorming with Dr. Rusthoven and the study VA champion on accrual barriers and potential solutions. Howard Krongard, older adults community advocate, has been introduced to Dr. Al-Jumali and Dr. Cole to collaborate with them on his trial. I'd be glad to make connections for S1914 as well, and any other concepts as we move forward. So please keep these in mind and let me know if I can make any connections for you. As always, it's a pleasure and an honor to work with all of you. I really enjoy this role. Thanks so much.
Thank you, Judy. So a few more housekeeping announcements. First of all, I'm controlling all the slides, and we have many slides here. Secondly, unfortunately, because of the time constraints, we won't have an opportunity to do polling, but we do have a chat. So I know some of the PIs are very interested in your comments. So if you could make a comment in the chat, I'm sure that they would also all be happy to hear from you via email with any thoughts, because again, it's really about our focus now, as I said, why we continue to develop new trials. I am truly focused on accruing these trials that we just opened and accruing them in a timely manner. So we need everybody's help to do that. And then I do want to introduce, I'm sure you've already heard this, but just in case you haven't, Ann Chang. Don't know whether Ann is on. Yes, she is. I see her name right at the top here. Ann Chang is our new executive officer for the Lung Committee. You may all know that Julie Graylow was our previous fantastic as well executive officer, who is now moved on to a role in a very important role in ASCO, and Anne was selected to take her place. We're really excited because Anne is from the Lung Committee, and so that's going to be very helpful to us. So just wanted to, everyone should already know Anne, and we're looking forward to her advice and guidance in her new position. Okay, with that, we will now go into our thoracic surgery session, and I'm going to turn this on over to Dr. Hofstetter.
Hi, Karen. Thank you. I apologize for my voice up front here. I just want to talk briefly about some of the surgical trials that are running in early stage lung cancer through SWOG and intergroup. As you all know, the intergroup ALCHEMIST trial continues to accrue and has been very successful in multiple areas. This is a screening trial that was involved with standard of care and targeted therapy. The EGFR and ANVIL sides are both already accrued and closed. The ALK inhibitor, crizotinib, the planned accrual is about 390 patients. That's still active. And I think that Janelle was talking about 81801 with the chemo pembro is still active. Next slide.
I'm multitasking here.
No problem. So accrual over the last month, you can see those that are closed have reached full accrual, and some that that are not totally accrued are a little bit slow. And as expected, the ALK trial is going to be a little bit slower, a little less popular in terms of its subtype within lung cancer. So no accrual over the month. It's still less than half of the overall planned accrual. So those of you who are signed up for ALCHEMIST, please continue to push the screening side so that we can get those ALK patients onto the studies as appropriate. The Pembro trial is at 80. Next slide. Janelle will talk a little bit about this. Karen, do you want Janelle to talk about it now, or she's going to have her own session?
Yeah.
Go for it, Janelle. You're up.
Hi, everybody. Yeah, so we have the adjuvant chemo IO trial that I serve as the champion for SWOG and work with Jacob Sands on this. Next slide, please. So we know, I think most of us know this, the background of why we're adding pembrolizumab to adjuvant chemotherapy. This is really based on the data from stage 4, later stage lung cancer, and now moving this into an earlier stage. And we think, at least based on the ECOG 1505, this should at a minimum be feasible, that triplet combinations in the adjuvant setting. And it's reasonable to move forward with exploring and investigating this. Next slide, please. So in the setting of adjuvant chemotherapy, what has happened before, the response rate has been very important. And you can see here that we get better responses with chemo-pembro versus chemotherapy alone. Next slide, please. And more data from this in the later stage trials now. So first that was 21G, which led to these Keynote 189 as well as the Keynote 407. Again, the response rates here are increased with the combination therapy. Slide, please. And so here's the original design of this trial, and you can see it really feeds into the ALCHEMIST trial. Need to pre-screen those patients, get that EGFR ALK status as well as the PD-L1 status, triage patients accordingly. For those that are ALK negative for now, because I believe the EGFR arm is closed, that they will be randomized to one of these 3 areas here. Either they get a platinum doublet followed by observation, a platinum doublet followed by pembrolizumab, and a platinum or upfront platinum doublet plus pembrolizumab followed by pembrolizumab out to about an additional year of treatment. Now, this one thing with this study is that it does allow post-operative radiation, so we'll need to make sure that we follow patients closely regarding that, in particular with potential risks for increasing pneumonitis. It also does mandate that patients have brain MRIs, so we can feel safe that these patients are being staged appropriately, as well as specific surgical criteria. Next slide, please. What's coming through now is that the pembrolizumab, we know, is approved every 6 weeks for 8 doses. And in order to minimize the burden on the patients and help with recruitment, that we think this is going to be very important to get this executed, that now they go down as far as the total number of doses, in which case they can come in for less visits. And I think this will be very important addition to an improvement on the study. Next slide, please. The amendment, as I mentioned, will impact the pembrolizumab dosing. We will also have the postoperative radiation therapy. And the requirement for the credentialing of the center will need to be removed. So again, relieving that, making this easier to enroll. And we will also accept now local test results, including the E1L3N, and not mandate, for example, the 22C3 assay. Next slide, please. Quality of life is a part of this study, and we'll be taking at specific time points. And again, it is important that you do submit those FFPE blocks as well as blood tube collection specimens for registration, for proper registration, in order that we can have a 360 view of patients from response as well as to correlates. The eligibility has also been simplified. I do remind people, I know we are almost at 9th edition, but this study was started under the 7th edition. We do require that your pathology reports are reread by 7th edition Appreciate the partnership from the pathologists across all of the sites recruiting. I know this has been a little bit of a challenge. Patients, again, cannot have an EGFR and ALK mutation, no active cancer. They must be eligible not only for adjuvant chemotherapy, but as well as a checkpoint inhibitor therapy. And we really encourage you to leverage the ALCHEMIST trial to help pre-screen patients, not only for this trial, but also for the ALK component of this. I think that should be, and then I think I went through most of this already. The genomic testing and the PD-L1 testing through the ALCHEMIST umbrella protocol will need to be done prior to enrollment, which then helps facilitate enrollment subsequently on this study. And we do have some central requirements and then adding some more leniency to enrollment.
Thanks, Janelle. I just want to state that in case you hadn't heard that the Empower 010 trial is positive, that's the adjuvant atezolizumab trial. We anticipate that it will be presented at ASCO. So I think that makes this trial even more exciting, as well as to see the results from the previous study. So that'll be really fascinating to hear about at ASCO.
Yes, very exciting.
Yeah.
Thank you for that update, Karen.
Just a positive press release, positive for disease-free survival. So they always give us that tantalizing little hook there. All right.
When do you expect to hear about Anvil?
What?
When will the Anvil report out?
It's still going to be a while, I
Maybe a
believe,
little
at
bit,
least a year or so is my understanding.
Because they use survival as the endpoint, right?
Yes, they did. So probably longer than that. Take that back. It'll probably be longer. We'll see. We'll see if they make, well, we'll see. That's okay. Wayne, do you want to introduce Ray if he's
Sorry, I was
on?
just
Or?
unmuting. So the
Oh.
upcoming trial, which has been gone through CTEP, and I think that Ray is on. I haven't seen his face though. There he is. Hi, Ray.
Yes, I am. Sorry, I have to wear a mask.
Okay.
Can I go ahead, Wayne?
Yeah, your floor.
Oh, cool. Thanks. Good afternoon, everybody. Really excited to give an update on the next generation superior sulcus trial that we've been working on for a while now. The name is NASIST, as you see, neoadjuvant chemoradiation plus minus immunotherapy before surgery for superior sulcus tumors. And you see all the internal leaders that we have on the team here. The immunotherapy we're going to be using is atezolizumab. Next slide, please. So by way of background, I will remind everyone that superior sulcus non-small cell lung cancer is, as lung cancer goes, something of an orphan disease. It's relatively uncommon, and therefore clinical trials in this space have been hard to do. It's a uniquely morbid subset of lung cancer because superior sulcus location makes it likely to catch on critical structures that cause a lot of pain and other symptoms. The space is relatively hard to get at. So single modality things like surgical resection and so on have traditionally been less than satisfactory. And ultimately, the orphan nature of this cancer has made it where the last clinical trial that changed practice is now about 2 decades old. It was a phase 2 trial, a non-comparative phase 2 trial that demonstrated that chemotherapy, radiation therapy followed by surgery made enough of a difference compared to historical controls that practice aligned with those results. So here we have the opportunity to add an immune checkpoint inhibitor as a new wrinkle to this, the treatment for this orphan lung cancer. And here's the schema for NASIST. It's basically, as you recall, to be called superior sulcus, patients have to have locally invasive primary tumors, so T3 or T4. we're restricting this to N0 or N1 patients and insisting that our patients have to have PS0 or 1. So the first step that everybody gets after randomization, which is 1-to-1, is everybody gets neoadjuvant chemoradiation therapy. The chemotherapy choice is a restricted dealer's choice. Those who insist on cisplatin will get the ability to use that. Those who prefer carboplatin will get the opportunity to use that. The doublet chemotherapy will be a narrow range of taxane or pemetrexed or VP16 for those who still prefer to do that. Upon randomization, everybody gets that. One group will get atezolizumab. Right now, we are still fighting with the NCI to let us do the trial the way we have designed it here. So arm 1 will get, along with 4 cycles of pre-op chemotherapy, would get atezolizumab along with the concurrent radiation therapy. And then upon completion of that, would go on to surgery. And then upon recovery from that, would go on with a year of maintenance atezolizumab. That is still a little bit of a bone of contention. As recently as yesterday, we got word from CTAC that they still want to debate this issue with us. And that's at a meeting that's coming up on the 4th of May for everyone who needs to be on that call. The other arm would get what is today still our standard approach, which would be that same chemoradiation therapy, and then upon completion, surgery, and then maintenance, no maintenance therapy, but long-term surveillance. Our hypothesis here is that the addition of atezolizumab will transform outcomes, whichever ones, event-free survival, pathology complete response, and so on down the line as you see. Next slide, please.
Okay. Oh, so this is wrong then. Sorry. This looks like it's wrong. Right.
Yeah. Well, I guess we don't need to dig too much into stats. You know, Yinchi Zhao, Mary Redman, and that superb crew tell us the numbers are right. NCI has not quarreled with our numbers, at least not in the most recent iteration. So we're good. We're essentially looking to enroll, I think, about 70-ish patients over the course of slightly less than 4 years, which sounds like a lot for only 70 patients. But remember, this is a relatively orphan disease. Next slide, please. We have some exciting translational things that we want to do. So the previous intergroup single-arm phase 2 trial of superior sulcus 2 decades ago showed these exciting results that everybody was happy with. One little clangor about it was it turned out CT scan appearance at the end of chemoradiation therapy did not in any way, shape, or form predict what was ultimately found at surgery. So patients who looked like they had progressive disease at surgery, some of them were found to have had a past CR. Patients who looked like, you know, they were doing great at surgery, some of them were found to have residual disease. So radiologic prediction of resectability and what you would find at resection turned out to be too much of a crapshoot for anybody's benefit. So we have this opportunity now in the age of PET-CT scanning with diffusion-weighted MRI scanning to actually look at ways to predict who is likely to be able to do well with treatment at the time of surgery. We also have some radiomic work that we would like to do. And Chad Wright, I really want to give Chad a shout out because he had to do some extra labor in response to CTEP's feedback to us late last year. We also, because this is a rich source of biologic specimens because of the anatomic location of superior sulcus, we feel we ought to be able to get plenty of tissue material to do plenty of translational biology work. So we've got all this work with both, collecting tissue at baseline and also obviously at surgery, and we hope at the time of recurrence for those unfortunate to have that, as well as blood biomarkers to be able to ask questions about the translational biology of non-small cell lung cancer. So that's an exciting component that we have with this. We have a really good partner in Genentech. They're really up for this. Not only are they providing drug, but they're also going to support quite a bit of the translational work that we have proposed here. So this, I think that's probably my last slide, maybe, or maybe one more.
One more.
Yeah, and we're excited about this. This is an orphan disease. Therefore, we think we need the intergroup mechanism to be able to make this fly. It is a high-value subset, despite its orphan status, because of the morbidity and the fact that this cohort of patients tend to lag behind everybody else. Surgery is hard to do, this and that. The radiologic things are tough. There's translational work that can be done here. I think this slide just touches on the radiologic objectives for the work that Chad has put together for us. Basically, we're asking the question, will modern radiologic techniques, whether it's PET-CT scanning, diffusion-weighted MRI scanning, prove to be superior in predicting what you find at surgery for patients than conventional CT scanning? And then we're also going to do some radiomic things, basically using the pixels that you get and making mathematical calculations out of them to see if you can squeeze out additional knowledge from that work. So really excited about this. We hope that our meeting on the 4th of May will be just about the last time we have to deal with this. The feedback that we got was not too difficult to deal with. I think the tightest one, the most uncomfortable one, is the fact that we yet again are being asked to come and litigate this issue about consolidation atezolizumab.
Yeah.
Karen, I'm going to hand it back to you.
Well, thanks, Ray. I do want to stop here and see if anyone has any questions. You gave a really nice overview. I do think, this trial is jam-packed with a lot of correlatives, and we're really excited about the radiology and incorporating radiology into this study. So, but remember, this is going to be the study. There won't be another study for another 20 plus years. So this is truly the opportunity to modernize this regimen for these patients. And, really SWOG was a leader in this in the past, and so we should lead the way here as well. So any questions here? I think, Ray, what is the target date for the OEWG target date?
Yeah, it's September this year. We would
Okay.
like to come in well before that.
Yes. So everyone here on the call, this is coming. This is going to come. So just FYI, this is coming, and it is a rare tumor. We do need everybody to activate this study too. So help us out as always. We appreciate you. All right, I'm going to turn it back over to Wayne. I don't see any questions. You did a really great job. There are no questions right now. You'll get the questions once it's activated.
Okay, were there any additional slides for the surgery? Okay, so this is the S1619. We presented this in the fall meeting. It actually is close to accrual. This is 24 patients with resectable mesothelioma. Last I spoke with Ann, when the readout's going to be, the response was long time. So when we hear back more about the results, we'll report back to you all.
No, we did submit an ASCO abstract, and I have to give Ann a lot of credit. We submitted that at the very last minute. Ann, thank you so much, and the whole team for that hard work there to get that abstract in. And here's just to refresh everybody's
This
memory
was
about
the
this.
schema. It was, yeah, cis pemetrexed plus atezolizumab for 4 cycles, looking at post-surgery, what the response was overall.
Yeah. Okay. All righty.
All right.
We'll move. Any questions? All right. We'll move now on to thoracic radiation. Dr. Decker.
Thank you, Karen. So hi, everybody. So I'm excited to report we have a number of active thoracic radiation trials to talk about, and actually a very healthy number of external trials for which we have study champions. So I think I will, we're going to start off talking about the open trials, and we're going to start with Chad Rusthoven. Chad, if you're on, I will let you take it away.
Yeah, great. So thank you, Roy. Thank you, Karen. So this is the SWOG S1827 trial, so-called MAVERICK trial. This is a trial for patients with small cell lung cancer, both limited and extensive stage, and it's a randomization to brain MRI surveillance plus or minus PCI. Next slide. So we've presented this trial a few times, and so just very brief background about where we are currently and where we may be headed. So this is the NCTN guidelines, the current version for small cell lung cancer. And I just want to highlight here at the top in green, for patients with limited stage lung cancer who have had a response to first-line therapy, PCI is still a Category 1 recommendation for patients, and that's based on a meta-analysis actually from 1999 that showed a 5% overall survival benefit at 3 years with the addition of PCI. And so that's still the best evidence on this question for limited stage patients, and that's why it's a Category 1 recommendation. For extensive stage, PCI is a standard option. And the reason that it's kind of a plus-minus is because there's conflicting data from randomized trials. One is from the EORTC that was published in 2007 that suggested a significant survival benefit. And then more recently, a Japanese trial suggested that for patients with extensive stage, that MRI surveillance alone was not associated with a decrease in overall survival. So we have conflicting data, and that's why it's a standard option that can be offered. And then over in the purple square on the right, the Japanese trial led to the recommendation that MRI surveillance would be recommended for all patients regardless of PCI status, both limited and extensive stage. Next slide. And so that leads us to our schema. So this is the MAVERICK trial, MRI brain surveillance alone versus MRI surveillance and prophylactic cranial irradiation, a randomized phase 3 trial in small cell lung cancer. And so on the left, you see this is a trial that includes both limited and extensive stage disease. And it's a rather straightforward randomization. Patients are randomized 1-to-1 to prophylactic cranial irradiation, and then all patients receive MRI surveillance. The primary endpoint of this study is overall survival, and there are a number of other secondary endpoints, including cognitive function, the survival outcomes in limited and extensive stage separately, and some translational endpoints. The MRI brain surveillance schedule is the same as the Japanese trial, and it's consistent with the NCTN guidelines every 3 months during year 1 and every 6 months during year 2. I would just highlight that, sorry, you may hear that in the background. My windows are being cleaned as we speak here. Hippocampal avoidance PCI is allowed, and we track that prospectively. So the radiation oncologist just declares their intention to offer hippocampal avoidance if they want to, and we'll track that for planned subset analyses. Hippocampal avoidance whole brain is also allowed, and so is salvage radiosurgery. This trial is really designed to be maximally welcoming to really any form of first-line therapy and different acceptable management strategies. We really tried to prioritize low barriers to accrual, and we have a baseline posture to allow dual enrollments onto other trials when patients are interested in that. Next slide. So just a couple of brief notes. So this trial is open across the NCTN, SWOG, NRG Alliance, ECOG, as well as recently was activated in the CCTG, and this week we had our first Canadian enrollment, so we're excited about that, hopefully the first of many. And we're also specifically championing this study in the VA system, and we have a dedicated VA study champion in Drew Moganaki. The study was activated in January of 2020, which, as everyone knows, was right before the COVID pandemic. It's open now at over 200 sites. Accrual has been slower than we would like. It's actually at 35 as of this morning. There are a number of reasons for this that we can consider, the COVID disruptions of local research practices, as well as competing trials in the small cell lung cancer space. And then also, as we were talking about in the working group yesterday, it is a bit of a challenging randomization when we offer this to patients to consider brain radiation versus no brain radiation. And both of these treatment options are available to patients off trial. And so that does make it a bit of a challenging randomization because physicians and patients often have strong feelings about the role of PCI in this setting. I think one of the things that we've learned in the last year is that framing is a really important component of successful accrual for this trial. So, as we went over with the NCCN guidelines, PCI is still a Category 1 recommendation per the NCTN guidelines for limited stage disease. And it's also been the historical standard of care for extensive stage disease, and we have conflicting randomized data. We know that PCI always cuts brain metastases in half in prospective trials, and that can be a really important thing for patients. And that's enough for some patients to want to go on to receive PCI regardless of the survival benefit. And when I present this to patients, I highlight all of these things, and I also just point out that the MRI surveillance alone is the experimental arm in the study, and we're trying to see in a large North American trial if MRI surveillance alone is associated with equivalent outcomes to a strategy involving PCI. Again, it's a very pragmatic study design that allows really any and all first-line therapeutic approaches, including hippocampal avoidance, PCI, salvage radiosurgery, salvage whole brain with hippocampal avoidance, and immunotherapy is allowed. One of the things that I do at our center when I'm presenting this trial is that I mention that, if a patient is randomized to the PCI arm, that we would offer hippocampal avoidance PCI, which may be associated with lower toxicity to cognitive function, and we also offer memantine. And again, our baseline approach is to be welcoming to dual enrollments wherever possible, and I'm always happy to answer any questions that people may have via email. So thank you very much for considering this trial. It's a really important question, and we really do need your help in answering it, and we thank you for opening it at your centers.
Thanks, Chad. Are there any questions or comments about this? If not, we can move on. So, yes. So, Chad, while you're still on, you want to talk about these briefly?
Yeah, absolutely. So, this is a recently activated trial. It's NRG CC009. This is also a randomized trial for small cell lung cancer patients, but this trial is for patients who have already developed brain metastases. This is a phase 3 trial of stereotactic radiosurgery versus hippocampal avoidant whole brain radiation. The PI is Dr. Vinay Gandhi, and I serve as the co-PI with this excellent group of investigators. Next slide. So by way of background, so for small cell lung cancer, whole brain radiation is the standard of care. There are a number of reasons for this, but in brief, in the landmark trials that establish radiosurgery alone for patients with limited brain metastases, small cell lung cancer patients were excluded from those trials. One of the concerns in small cell is that there's a concern that some patients will develop short interval CNS progression, and that this could potentially decrease overall survival in those patients, and that's made the oncology community a little bit nervous about withholding whole brain in these patients. However, at the same time, we also know that whole brain radiation can be associated with toxicity to both cognition and quality of life. There are various strategies that can be used to mitigate this. One is to use radiosurgery alone, but there's also memantine, hippocampal avoidance whole brain, as well as emerging systemic therapy alone strategies. Next slide. So over the years, there have been a few smaller studies that have suggested that radiosurgery can be a reasonable option for the upfront treatment of brain metastases from small cell lung cancer. And this was a study that we got to participate in and help lead that was published last year that brought together a number of institutions across 3 continents in Asia, North America, and Europe. And this was called the FIRE SCLC study, and it was a large retrospective analysis where we pooled together patients who were treated with first-line radiosurgery for small cell lung cancer. And we were able to get over 700 patients, and then we matched those and compared them with patients who were managed with upfront whole brain radiation. In match pair analyses, we found that, as expected, the time to CNS progression was shorter with whole brain radiation, but there did not appear to be a survival benefit with whole brain radiation in this cohort. And so when you look at that, it looks quite similar to the trade-offs associated with whole brain versus stereotactic radiosurgery in other histologies, and it suggests that maybe radiosurgery in small cell lung cancer has a similar risk-benefit profile. There are some other encouraging things, like the majority of patients who required salvage therapy underwent further radiosurgery rather than whole brain, and the rates of leptomeningeal and neurologic mortality were low. Next slide.
Oops, sorry.
In the past few years, there's also been some practice-changing data on how to deliver whole brain radiation with less toxicity. The RTOG 0614 suggested that the addition of memantine to whole brain radiation was associated with better cognitive function outcomes. And then building on that result, the NRG CC001, which was published last year in the JCO, suggested that hippocampal avoidant whole brain radiation was also associated with better cognitive outcomes. And this has made hippocampal avoidance plus memantine the standard of care for offering the least toxic version of whole brain radiation. Next slide. And so that leads us to our schema. So this is NRG CC009. It's a phase 3 trial of stereotactic radiosurgery versus hippocampal avoidant whole brain radiation for 10 or fewer brain metastases from small cell lung cancer. This trial was activated recently at the end of February 2021, and so we're kind of in the local site activation phase where it's being brought to local centers who wish to participate. So if you're interested in this trial, it's a good time to look at opening it, and I'd be happy to answer any questions that you may have. Please feel free to email me. The criteria for enrollment are patients with small cell lung cancer with brain metastases, 10 or fewer brain metastases, and some volume requirements, and a performance status greater than 70. Patients are randomized. It's a straightforward randomization to stereotactic radiosurgery alone versus hippocampal avoidant whole brain radiation to 30 gray in 10 fractions. The primary endpoint of this trial is time to cognitive failure. The sample size is 200 patients, and the hypothesis is that radiosurgery will be associated with better cognitive performance than hippocampal avoidant whole brain.
Thanks very much, Chad. If there are no comments, Megan's going to come talk about the NRG on the SWOG on 1914. That's what she gets for putting that on the slide.
Thank you. Yes, this is a collaborative trial with NRG. So this is SWOG NRG S1914. It's a phase 3 randomized trial for early stage medically inoperable non-small cell lung cancer, comparing radiation alone to radiation with atezolizumab. This slide highlights the schema for S1914. Eligible patients have early stage medically inoperable non-small cell lung cancer or have declined surgery, and the patients will be randomized between standard of care stereotactic radiation alone over 3 to 5 sessions, or stereotactic radiation in combination with neoadjuvant, concurrent, and adjuvant atezolizumab for 6 months, right, up to 8 cycles total. Atezo is given every 3 weeks for up to 8 cycles, and patients are stratified based on central versus peripheral tumor location, size, less than 4 or greater than equal than 4 centimeters, and Zubrod performance status. Our target accrual is 480 patients with a goal of accruing these patients over 60 months. Next slide. This highlights our patient eligibility. Patients need to have a biopsy-proven stage 1 to 2A non-small cell lung cancer. A subset of T3 patients are permitted to enroll as well based on size. They can have a tumor up to 7 centimeters if appropriate dosimetric constraints can be met. And patients do need to have at least one high-risk feature that suggests an elevated risk of regional or distant tumor failure. That can be a tumor diameter of 2 or more centimeters, a tumor SUV max of at least 6.2, or moderately, poorly, or undifferentiated histology. Again, patients do not need to have all three. They need to have at least one of these 3 high-risk factors. They should have no evidence of hilar or mediastinal nodes, and they should be medically or surgically inoperable or have clearly a documented unwillingness to undergo surgical resection. And we do require FDG PET staging within 3 months and CT within 42 days. Next slide. So we do have a pending amendment, and I just received an email about an hour ago showing that it appears to have been fully approved. So I believe this will be activating momentarily. This first includes several corrections that were pointed out by some of the earliest investigators enrolling to this study related to some of the radiation dose volume constraints. There were some questions about, for example, whether rib and chest wall constraints were mandatory or were guidelines. They are guidelines, and that it will be clarified in the pending amendment. It also importantly relaxes the eligibility criteria around prior or concurrent malignancies. I know a number of investigators had had difficulty enrolling patients who had had a prior lung cancer several years ago. Those patients will now be allowed to enroll. Essentially, any patient can enroll as long as a prior or concurrent malignancy does not have the potential to interfere with the treatment. It also, our amendment adds an optional quality of life questionnaire and includes the background materials and endpoints for the quality of life section. And we have added an additional section 8.4 to help clarify response assessment criteria, given this is always a challenging area in the SBRT space. Next slide. And then finally, I did want to just kind of put in a plug for our trial. There are several other large randomized phase 3 trials open around the country. There are 2 very directly competing trials for the same patient population, both of which are industry sponsored, the Pacific 4 trial and Keynote 867. Well, we believe all 3 trials are excellent studies. We do think our trial has certain advantages for patients, including that S1914 uses a shorter duration of immunotherapy, only 6 months as compared to the 24 or 12 months of the other studies respectively. Importantly, we do not require placebo infusions, which is very appealing to many patients. Our timing of immunotherapy, where we include 2 cycles of induction at TEZO, is based on preclinical data showing increased synergy between SBRT and immunotherapy. And finally, sites can gain accrual credit with cooperative groups when accruing on S1914. We have currently enrolled 22 patients. So while accrual is picking up significantly, we are still certainly behind schedule, and we would love to get more sites on board. And please feel free to reach out to me with any questions at all about the study.
So again, I just want to say, if there are questions, please put them in the chat, and we can answer them via chat, or Dr. Daly will be happy to answer them via email as well.
It's a quiet group today. So thanks, Megan. This is a great study, and I would really encourage everybody to open it. It's actually an easy randomization. Our next study is the 1933. Dr. ALCHEMIST, if you're here.
Yes, I'm here. Thank you, Dr. Decker. So this is a pilot study of hypofractionated radiotherapy followed by atezolizumab consolidation stage 2 or 3 non-small cell lung cancer patients with borderline performance status. So the target patient population for this study is either stage 3 non-small cell lung cancer with performance status 2 or stage 2 patients who are not surgical candidates. So this is a patient population that we don't have data to guide treatment decision because those patients were excluded from the randomized phase 3 studies that set the standard of care. We don't have data for efficacy and safety of concurrent chemoradiotherapy, and patients who have stage 2 and not surgical candidate, we don't have data to guide treatment decision. Patients who fulfill the enrollment criteria receive hypofractionated radiation therapy, which is 60 gray and 15 fractions. Then 2 to 5 weeks after completion of radiation, get scans. If scans show no disease progression, then receive 1 year of atezolizumab. So I think it's a good study. Help us to has a potentially curative chemotherapy free option for this patient population, and help us to treat those patients and have data on this patient population that we don't have. And this patient population is there, and looking at multiple studies, patients with lung cancer present to the clinic. About 30% have performance status 2. So, the key is to remember that study, remember to screen those patients. I treated patient completed the radiation, tolerated well, and responded, and we'll start him on atezolizumab. So I have another patient likely will enroll on the study, but I need help from my colleagues and friends to remember the study and enroll patients.
So I'm just going to skip through these. So does anybody have any questions? We really do need help on this study. So it's open at many sites. For those of you who have it opened, is there some issue that you're having, barriers to accrual or screening issues? Again, please put those comments in the chat. That would be really great. We really do think that this is a very good trial, and Rod did say that correctly. There are these patients out there, so really do want to know your thoughts. Meanwhile, we will continue on. Roy, we are just a tad behind, but
all right. We'll speed it up. I'll just say that short course radiation is very popular in I think in many large practices. So for all those out there, if you're running into some resistance or questions from your radiation oncologist, please refer them in, and we're happy to chat with them about if they have any reservations. So we have a number of studies for which we have SWOG study champions. So Karen, do you want me to do these, or do you want me to have the study champions do these?
I would like the study champions to do it. It's an opportunity for them, and they are working hard on these as well. So we'll just do them very quickly. So
all right. So Matt Harkenreiter is going to talk about ECOG-ACRIN 5181, assuming he is here.
Yes, I am. Thank you, Roy.
They're
Thank
all
you,
here. They're
Karen.
all here.
Yeah, so this study is led by ECOG-ACRIN and builds on the Pacific trial data, randomizing patients with stage 3 non-small cell lung cancer to the Pacific arm of chemo-RT, followed by 1 year of consolidated durvalumab, compared to chemo-RT, the same consolidation durvalumab, but adding a concurrent phase of Q2 weekly durva with the platinum doublet and the radiation therapy. So really looking at moving that durvalumab up into the concurrent phase, which is a very important question. Stratifications there on the left. Primary objective is overall survival. Accrual goal 660 patients. This opened last summer, and it's accruing well with 125 patients to date, 13 of which have come from SWOG institutions. So thank you for your support of this study, and I'm happy as well to answer questions via email if there's anything about this study.
Thanks.
Are there any concerns about this study from from ECOG? It's going smoothly. No issues. No amendments.
It seems to. There isn't anything that's that I'm aware of.
Thank you.
Okay, and Charles?
No. I'm not sure if Charles, if Charles is able to make it. I think he emailed me saying he may not. Oh, yeah, he's here.
He should be here.
Yeah. Charles, you're muted. I tell you what, do you want to maybe go to the next one and we can go back?
Yep, that sounds good. So Henry Park.
All right, thank you very much. So I'll be talking about NRG LU007, the Raptor study. This is looking at consolidated thoracic radiation versus observation in extensive stage small cell lung cancer. Next slide, please. All right, so here so the idea here is after the CREST trial that showed the benefit of consolidated thoracic radiation in extensive stage small cell after chemotherapy. The question remains if this benefit still applies after chemo and immunotherapy after the Empower data had come out. So what this is looking at is using an EP doublet and atezolizumab for 4 to 6 cycles. For the Empower study, if you have no progression, then staying on maintenance tezo afterwards. But then the question is whether you add radiation to 1 to 5 sites afterwards. So not only consolidated thoracic radiation, but also up to 5 sites of treatment. But not necessarily that has to be 5. The phase 2 the 3 study and overall survival with secondary objectives looking at toxicity, the idea of complete versus incomplete consolidation, meaning whether or not you actually radiate every site of disease that they have or not, and then also looking at 1 to 3 versus 4 to 5 sites. This is stratified based on the sites, the number of sites getting radiation, whether it's up to 3 or more than 3 sites, whether or not you've had a partial response or stable disease, and also ECOG performance status. The radiation is given to a low to intermediate dose. So thoracic or liver radiation can either be 45 gray in 15 fractions or 30 gray in 10 fractions, whereas any extra thoracic radiation will be 30 gray in 10 fractions or 20 gray in 5 fractions. And both arms get atezolizumab maintenance. This is activated in, and then the other key point here is that there is co-enrollment is allowed with the MAVERICK study. So I highly encourage you to enroll in both studies as well. There's also the recent amendment 1 is pending currently. Overall minor changes, but I think the most major one is that it also encourages co-enrollment on NRG CC003 as well, which is the hippocampal sparing versus standard PCI study, which is going to be open for a little while longer. But of course here, we very much encourage the MAVERICK study for co-enrollment. In terms of activation, it activated in August 2020, of course, with COVID, as you all know. Took a while for centers to get approved and for them to open at their own sites. So currently there are only 2 accruals as of a couple of weeks ago, both through NRG. They're gonna start setting up. I just interacted with the PI recently of the trial, Quinn Win, and she said that they're gonna plan on a monthly meeting soon to start discussing barriers to accrual here. So this is something that maybe I think very helpful study to enroll on to answer a very important question here. So consider Raptor as well as MAVERICK study because we can get SWOG credit for both studies.
Yeah. All right. Great names. Okay, I'm going to go back now. Charles had to step away, but I believe he is back, and we'll just. Charles?
Not be pulled. So just real quickly, kind of as a quick segue after LU007, this is for LU005, limited stage small cell, question of whether or not to add atezolizumab concurrently. So our main PI is Kristen Higgins, co-PI now is Tom Stickham. So in terms of, I'm going to move next slide. So basically, it's a phase 2/3 study. Current accrual right now is at 221 as of March 31st. And so the primary objective is to determine whether the addition of atezo concurrently to chemoradiation for limited stage will improve both progression-free survival and overall survival. So with respective hazard ratios of 0.6 and 0.7 for PFS and OS. And then you've got multiple other secondary objectives, including ORR, local control, control, as well as quality of life metrics, tumor mutational burden, and whatnot. And again, limited stage, as you know, stratified by both the fractionation schedule, type of chemo, sex, and ECOG, and it's a 1-to-1 randomization. And just as a quick reminder for this, patients have to undergo 1 cycle of chemo, and that has to be declared, and this will be done prior to randomization. Radiation can only begin with the 2nd cycle of chemo, and when the immunotherapy would also be administered if the patient is randomized to that. And again, the strong recommendation is for PCI, so unfortunately, this study does not work with the MAVERICK trial, which is unfortunate. And in addition, they relaxed some of the imaging requirements for PET as well as CT. Brain imaging is within 30 days still. And they also now want hepatitis B or C testing if it was not tested before. So we just encourage everybody to try to accrue to this study. We think it's a great study, so thank you.
I think this study is accruing well.
Mm-hmm. No, definitely. Yeah, I mean, it's almost at that phase 2 level. Yeah. Yeah.
All right, for the LU06, Robbie Samstein, I think I saw you on here.
Yeah, I can be very brief. This is a study looking at the role of adjuvant radiation in the era for resectable mesothelioma and the era of pleurectomy decortication, which has become the standard of care, likely from a surgical perspective. But it's unclear the benefit of whether there is a benefit of adjuvant radiation. And the radiation is done with a sort of more sophisticated IMRT method called imprint that has been demonstrated to be both safe in a phase 2 study, but also seems to be associated with improved local control and perhaps a suggestion of an overall survival benefit. The study schema is relatively simple, where patients get pleurectomy decortication. They can get chemotherapy either before or after surgery, and then followed by randomization to radiation or not. Next slide.
Oh, sorry, just a second.
And the primary objective of the study is to look for an overall survival benefit in this cohort with the addition of radiation as adjuvant treatment in this sort of high-risk cohort. And the secondary objectives and exploratory objectives are listed. And the study is relatively small, 150 patients, as this is a small population, and they've accrued 4 patients so far since it activated about a year ago. The only current update that Andreas Ruminer, the study PI, asked me to share is that there is an amendment in the works that will allow for chemotherapy to be done locally to allow for better coordination with sort of high volume surgery centers that are doing the surgery, as they heard that that was a potential barrier. And they will be adding also the option of immunotherapy for some patients.
Thanks. So now we're going to move on to the translational medicine component. So Dr. Mack, you are up. And again, though, please put some comments in the chat if you want to, and everyone will be happy to respond via chat.
Yeah, so we're going to move through this relatively quickly to make up some time. We're a little behind, so go ahead and advance it, Karen. So you can skip through this. We'll be talking a little bit about how to predict long-term benefit. No, go ahead.
Sorry. Time's that.
From therapy in non-small cell lung cancer. So the premise is that if targeted agents or IO are resulting in kind of mediocre, less than 6 months progression-free survival, what could we have done to improve that therapy algorithm? It may not be the wrong therapy, it just may be insufficient. And so it is actually of use for us to know if we're going to have a therapy that results in this kind of middling responses. We want to put people on long-term benefit. And one of the main questions we're essentially be asking is, was there some sort of innate resistance factor that we did not appreciate, something that we could have tackled and augmented with an additional therapy or a different scheme? And can we identify these limited responders earlier? Next slide, please. Now, you've probably all seen the 1403 data. This one here is color-coded. So basically, we're looking at plasma levels at the start of therapy, end of cycle 2, which is 8 weeks, and at progression. And so what you see happening here is that almost every patient decreases in the amount of circulating tumor DNA. And our goal was to figure out what the significance of that. At the very short time of after 2 cycles, you can see that many of them, and those are the blue lines, actually clear completely to the point where they're no longer detectable. And then at some point when they progress, they usually come back up. Go ahead and advance it.
Oh.
68% of these actually cleared. And we were able to identify it's actually 80% now is the final number at baseline detection. Okay, next. And this matters a lot. This was actually turned out to be extremely predictive of how those patients did essentially long-term. Again, those ones that cleared, the ones that after initiation of therapy went from positive to undetectable, had a median progression-free survival of 15 months compared to 5 months for the ones that didn't. So it's actually quite predictive of progression-free survival. And if you move to the next slide, we'll see similarly, oops, go back one. It was also predictive of overall survival, whether they cleared or not. So this is giving us some long-term benefit indications. Other studies have been looking at this and starting to come out now, these early indicators using plasma. You can go to the next slide. This isn't our study, but here they're using an algorithm that they are deploying for IO-based therapies. Now, in our study, we were simply looking at EGFR as the primary marker, but here they're taking essentially a consensus of all of the ctDNA positive factors that they identified, P53, KRAS, whatever it happens to be, because obviously in your IO-based therapies, you don't have a single marker to follow. And here it's been discriminated as either complete response or greater than 50%. And you can see there, the red line is no molecular response, and those patients are doing quite poorly. So even for IO, you can see that early plasma is quite predictive. And if you move to the next slide, this is that data we just looked at was in a variety of solid tumors here. This is specifically in lung cancer, and this is just really hot off the presses. They're using the exact same algorithm, using the Garden technique, and this is a good way to segregate patients treated with IO into molecular responders or molecular non-responders. And again, just look up there in the top left corner, just how short the median progression-free survival is for those that are not clearing their ctDNA. Now, advance it one more time. So why do we actually need this? Can we just rely on RECIST response on scans to predict this? And the answer appears to be no. And interestingly, Rayo had talked about this earlier in surgery about how it's not necessarily as predictive as one would want to be. This is from the 1403 data, but here we are looking at whether the patients responded or did not respond, and how that correlated with progression-free survival and overall survival. One would think that responders would do much better. But you can see there in progression-free survival, it's really not that predictive. In fact, those lines are crossing over. So you're talking about 9.6 months versus 12.1 at median and then crossing over. Overall survival, it does give you a little bit of separation, but not significant in our study. So if you move to the next slide, this is just a table, a fun broken table, that is, go ahead and advance it one more, you might clear off the white line there. Okay, here we're looking at just the numbers from what we just saw. So on the right, the plasma clearance at 6 weeks is giving us statistically significant data with p-values less than 0.1, and the RECIST response is not being that predictive. So the plasma is a very useful way to anticipate whether you're going to have these long-term benefits or not. In many cases, a lot of these patients are responders, and they just don't clear their ctDNA, and they just don't respond for very long. And I wanted to particularly bring this to your attention because we will be incorporating this strategy. I don't know if there's any more slides after this, Karen, but we will be incorporating this strategy into future clinical trials in SWOG. One potential one is the amivantamab lazertinib, which is in discussion. I shouldn't say any more about it. But this would use a ctDNA as a trigger for therapy augmentation if ctDNA is not clearing. And we have some local studies at Mount Sinai using a similar thing. And I think we'll see this more often. But we would love to see these types of plasma switch therapy strategies incorporated into SWOG as we move forward. And that's what I've got.
Thanks, Phil. I just want to ask you one question. What do you think is the optimal time period? You know, we've been doing 3 weeks and 6 weeks, but is there an optimal time period, meaning earlier being better than later?
Yeah, I thought it would be different for targeted therapies and IO, but everybody is circling in on the 6 weeks.
6 weeks.
For IO, 3 weeks may be too early, in that some studies have shown that you can start to clear, but you don't get full clearance until 6 weeks. So I like that 6 weeks time.
Okay.
In some patients, like you will see this, like, you know, in one of your crazy EGFRs that responds immediately and feels like better 3 days after you start therapy, you'll see ctDNA clear within 1 or 2 weeks. But 6 weeks is a good benchmark to be really sure.
Okay. I was just wondering, go ahead.
Question, is there any evidence that you have for the timing of ctDNA after surgical resection in predicting recurrence? I know Max Dean has his cohort, but that was predominantly a radiation therapy cohort. They had a sprinkling of resected patients in there, and obviously asking because of NACIST.
Yes. Yeah, no, I think it's very appropriate, and we were careful to build in the liquid biopsies into that, you know, not as a decision maker, but as something to study. And there have been actually some several surgical studies that have shown just a remarkable prescience of liquid biopsies. You know, if you can detect it after surgery, then those patients will relapse much faster. And I can send you, I didn't put it in here for the sake of time. But I think it will be at least as clean as it is, if not more clean than in early stage than it is in advanced stage.
Well, thank you so much, Phil. That was great. And I do think incorporating this more into our trials will be very informative. And I think you gave a nice segue into how important that is, even with the IO therapies. All right. Thanks again. So now we're going to move on to our scientific presentation. And it is certainly my pleasure to introduce Dr. Lauren Byers, who is an associate professor at MD Anderson Cancer Center in thoracic and head and neck medical oncology. She is well known for her breakthrough work in small cell lung cancer, and she's going to talk to us about her work in transforming small cell lung cancer through biomarker driven therapy, from black and white to technicolor, transforming small cell lung cancer through biomarker driven therapies. Dr. Byers, thank you so much. Looking forward to your presentation.
Thank you. It's really great to be here. Are you able to hear me?
Yes.
Perfect. And are you guys going to drive the slides? Or should I just? Yeah. Perfect. Okay. Great. If you can go to the next slide, please. So these are my disclosures. And next slide. So many years ago, when I was John Haymack and I were both much younger, I started doing some discovery work using proteomics in the lung cancer cell lines. And this really led to the observation that PARP and several other DNA repair proteins were significantly overexpressed in small cell lung cancer compared to non-small cell lung cancer. Next slide. And so we were really excited about this at the time because, at that point, there were a lot of PARP inhibitors that were moving into clinical trials for breast cancer and ovarian cancer, especially in the BRCA patient population. And so we really, prioritized PARP in terms of following up on that as a potential new targeted therapy for small cell lung cancer. And, working closely with Ignacio Westuba and his group, we were able to confirm that PARP was in fact overexpressed in small cell lung cancer and other high-grade neuroendocrine cancers. And then we started looking at different PARP inhibitors in our small cell lung models, so both in cell lines and in animal models. And what we saw was that there was a significant portion of these models where drugs like talazoparib had really striking single agent activity. Next slide. And so this led actually to the first trial where small cell lung cancer patients were specifically enrolled on an expansion cohort. This was the first in man study of talazoparib. And we looked at this drug in relapsed patients with small cell lung cancer, as well as, there were the other usual patient populations being studied on the trial in terms of BRCA1 and 2 mutant breast and ovarian cancer patients. And what you can see here from the waterfall plot is that, there were a subset of relapsed small cell patients who responded. It was, small numbers in terms of, those that had a resist response, but there were patients that, where we saw the signal of activity. But it was also clear, both from our preclinical work as well as from, the data that we had on these patients, that it was not going to be a BRCA mutation or another HRD, gene defect that predicted which of the small cell lung cancers were relatively sensitive to the PARP inhibitors. Next slide. And so, not too long after that, there were some really nice data from Yves Palmier's group where they were looking at a gene called SWOG-11, which I think none of us had ever really heard of and couldn't pronounce either. But they saw a signal in the NCI cell line panel that cell lines that had high expression of SWOG-11, which is a gene that causes cells with DNA damage to undergo replication arrest and cell death, that if the cell lines that had high levels of this were very sensitive to a lot of the drugs, that are DNA damaging agents that we routinely use in small cell lung cancer, so such as, topotecan and etoposide, the platinum agents. Next slide. And so, in small cell lung cancer, our group and several others, so Bev Teicher's group at the NCI and Charlie Rudin and others, were starting, to look at screens of PARP inhibitors in small cell lung cancer cell lines and other models, as well as in some of the, the big cohorts of lung cancer lines and other kind of banks of cell lines. And again, in each of our analyses, SWOG really emerged as being a top biomarker. So when that was high, those were the cell lines that were most sensitive to multiple different PARP inhibitors that we were looking at. Next slide. And so one of the things that we did was we actually had an opportunity to do a co-clinical trial in PDX models of small cell lung cancer and to use our proteomic platform where we were looking at 200 or more different potential protein markers to see if there were differences in terms of protein biomarkers in the PDX models that were sensitive to talazoparib or the ones that were, versus the ones that were more sensitive. And so you can see in the top right, there was this sort of waterfall plot representing the different PDX models that came from different patients in terms of 2 that were partial responders, 4 that were had stable disease, and then the others that were relatively resistant to single agent talazoparib. And when we looked at these, at this co-clinical trial, similar to what we and others had observed in the cell lines, the top marker of response or of stable disease was SWOG-11, and so we were really excited about that. And in order to validate that, we actually worked again with Ignacio Westuva's group and Junya Fujimoto, who's a pathologist with a particular interest in lung neuroendocrine cancers. And we're able to develop an IHC assay that we used initially in the mouse tumors, but then we're able to use that to then develop an IHC that could be used in clinical specimens from patients. Next slide. And so that really, gave us the opportunity to go back and in a retrospective analysis, see whether or not Schleffen was predicting differences in terms of benefit in small cell lung cancer patients who were being treated on this CTEP trial, which was led by Kathy Piatanza, and I partnered with her as the lead translational investigator. And really by the time we got to the end of the study, it had become clear that Schleffen was sort of the top candidate marker that we wanted to look at. One thing I think that's important when we think about, doing studies in these patients is that often, we know that there's very limited tissue from small cell patients. So even though this trial enrolled about 100 patients, only about half of those had enough tissue to even do, a single IHC, biomarker analysis. But we did this in the, patients where there was available tissue. We saw about half of the patients had expression of Schleffen, of the biomarker, and half of them were negative. And this was a 2-arm randomized trial where half of the patients received temozolomide with placebo and the other half received temozolomide with the addition of veliparib. And we were really, encouraged by the results, which was that in the, if we looked at progression-free survival or overall survival, the Schleffen positive patients had significantly longer overall survival when they had the addition of veliparib to their regimen. And so again, I think, retrospective analysis, subset of patients, but we were really encouraged by that. Next slide. And so more recently, you may have seen our cancer cell paper that came out where we've been able to identify 4 distinct molecular groups of small cell lung cancer. And these included, 3 that were transcription factor driven subsets. I think were, the ASCL1, NeuroD1, and PAU2F3, which had been predicted to be major players in terms of some of the molecular subtypes that were emerging. And then a 4th group that had not been previously characterized that we called the inflamed group because it had very high expression of multiple immune markers. And if you go to the next slide. So, the small cell inflamed group, the analysis from that, and we actually were able to validate these 4 groups in the Empower 133 trial. So this is looking at 276 patients from that trial that had gene expression data. And similar to what we had seen with our initial analysis where we identified the four subgroups, we again in Empower saw that there were very distinctly these 4 groups, that one of those was the inflamed subgroup, which makes up about 20% of patients. And that's the group where there's the blue box around a group of genes that define that particular subtype. And it's very enriched for genes associated with the interferon gamma activation, as well as STING pathway, multiple immune checkpoints, as well as HLAs. And here you can see, again, it was a retrospective analysis, but having the opportunity to compare outcomes between the chemotherapy arm and the chemo with atezolizumab, the patients who were in this inflamed group had a median overall survival of 18 months and made up, many of the patients that were in the tail of the curve as compared to 10 months in the rest of the patients who are receiving the addition of atezolizumab. And there was really no difference in outcome between the 4 groups in patients who were just receiving chemotherapy. So next slide. And, when we went back, one of the things I think we had predicted was that the ASCL1 group, which in our laboratory studies looked like about half of those ASCL1 small cell cancers were relatively sensitive in cell lines to PARP inhibitors. We predicted that Schleffen might identify a subset of those patients that were, that might be more responsive. And again, similar, I think, to our prior analysis, we did see that in that Schleffen A subset, which is the most common, subtype of small cell, that in the cell lines that, again, the ones that had high Schlafen-11 were much more sensitive to cisplatin, also much more sensitive to olaparib and to other PARP inhibitors. Interestingly, the PAL2F3 group, which was the more recently recognized transcription factor defining a different cell of origin of small cell lung cancer, were also very sensitive to the PARP inhibitors. Next slide. And so I think this, I think one of the things that we have all, recognized looking at the Empower and the Caspian data and even, looking at outcomes by subsets is that we need better, more effective treatments essentially across the board. So not just, it was nice that the inflamed subtypes seemed to get relatively greater benefit, but there was still, a need to improve outcomes, across, across all of the groups. And so I think that the data, having identified subsets that may be particularly sensitive to PARP and subsets that may respond to immunotherapy provide, again, further support for the idea that using a biomarker selected approach in small cell lung cancer could potentially really enhance the, the activity of specific therapeutic combinations. And so in particular, again, thinking about the Schleffen positive subgroup of ASCL1 in particular. Next slide. And so just to kind of show some practical aspects. Oh, sorry, if you go back one. Oh, maybe I'm wrong. Sorry, go forward. Okay, perfect. So anyway, I think that we've all been very excited to work on SWOG 1929. And so myself and Carl Gay are serving as translational PIs, and it's being led by Dr. Nagla Karem and Karen Rechtkamp as the study PIs. And so I think that this is really an incredible opportunity to move what has been one of the most promising biomarkers in terms of Schlafen-11 to predict PARP inhibitor sensitivity, and then combine it with immunotherapy, which we think has a lot of potential for the PARP inhibitor to further enhance response to immunotherapy. And next slide. So from a very practical perspective, I'll say, there are a couple of things that we really like about Schlafen as a biomarker. One is that it's expressed in about half of patients, and so it's highly prevalent. So we know when we think about, non-small cell lung cancer, for example, it's, we can find biomarkers for, populations of patients as small as, 3 to 5%, and they can be clinically meaningful. But I think starting from a point where we have a biomarker that is present in up to half of the patients is something that really helps with the feasibility of doing trials in this space. And then the other thing is that Schlafen expression is pretty clear cut. So half of the tumors have no expression, and then half of them have detectable expression. So almost similar to PD-L1, where you can sort of say either, is there zero expression or is there some amount of expression? You can kind of group the patients based on that. And next slide. And, down the road, the other, potential opportunity with this biomarker is that we have done some pilot studies with a company that develops CTC markers, and you can detect Schlafen directly on the circulating tumor cells. So there's a potential also that we could get to a point where we could use a blood-based marker to, specifically for this biomarker. And so again, I think, kind of a lot of potential in terms of thinking about practical aspects of patient care and how we might use this in the future clinically. Next slide. And so this is what I was referencing before in terms of, why we're interested in now combining PARP inhibitors with immune checkpoint blockade. And, we had hypothesized that because of the type of DNA damage that PARP inhibitors were causing, that they might have the potential to help inflame tumors that were otherwise not inflamed. And that's what we have seen in multiple models that we've looked at in our preclinical work. And so again, very excited to have the opportunity to translate this now, into the clinic and see, if this combination has activity, for patients who are being treated. Next slide. So this shows the overall design of the SWOG 1929 study. So again, being led by Dr. Karim, who is the clinical overall PI. So this is a phase 2 study of maintenance atezolizumab versus atezolizumab in combination with a PARP inhibitor talazoparib. And this is specifically for patients who are Schleffen positive, extensive stage small cell patients receiving their initial frontline therapy. And so you can see there's an initial sort of step 1 of the trial where patients receive standard of care chemotherapy with atezolizumab. And during that time, they're able to be screened for Schleffen IHC expression. So that is the integral biomarker. And then in step 2, patients who express the biomarker are then randomized either to the atezolizumab standard of care, arm, or the atezolizumab in combination with talazoparib. And the primary objectives are the primary objective is PFS with secondary objectives of OS, overall response rate, and AEs, and then translational objectives for there's a plan for potential future correlative studies that could follow on this. Next slide. And this again just shows kind of the basic inclusion for the study. Again, they all have to be Schleffen positive, no disease progression during their initial chemo immunotherapy, and then other kind of typical things. One thing to point out, patients may have asymptomatic treated brain metastases, and PCI and consolidative radiation are allowed. Next slide. Okay, so this kind of shows where we are now with the screening. So the study was activated in June of 2020, and there have been 73 patients that have gone through the step 1 screening, and so far 60 patients have received a result in terms of having evaluable tissue. There have been a few things I think that we would have predicted that have impacted whether or not that some subset of patients are not evaluable based on the available tissue. So some of that is just things like not enough cellularity, or patient had a mixed histology, things like that. So far, the patients that have been screened, there have been 15 that were negative and 47 that were positive, and 20 of the patients who are positive have moved on to randomization. And just to note a couple things, I think so far, just as far as the practical, the practical aspects of how this is going. So the median turnaround time for testing has been 6 days. So I think that has been great. Ironically, the one that took the longest time was one of our patients here at MD Anderson, because it was, I think, during the freeze, and they couldn't figure out how to get the sample from where it was to where it needed to be. And so that one took 15 days, was the longest time. But I think we finally figured out how to address that. But again, things moving forward, I think, quite well. And if you go to the next slide, please. So this highlights just an example of a couple of the patient samples that have undergone screening. And I just, first of all, want to say thank you for Dr. Billy Wang has really been an incredible partner. He's the one that has been overseeing all of the biomarker work and worked very closely with Dr. Carl Gay, who's in thoracic oncology with us. And they really, work together to validate this, get it into the CLIA lab, and now overseeing all the testing that's being done. And what Dr. Wang has said is that so far, the cases that they've gotten to review have been very, very clear cut in terms of, cases that are positive, as you see on the left, with the strong, brown staining versus cases that are negative. He has seen that if there's crush artifacts that you have to be cautious about, about interpretation of that, because it can lose some of the Schleffen labeling if there's crush artifact. But again, so far that it's been pretty black and white in terms of calling the cases positive or negative. And then next slide, please. And I think if Nagla is on the phone, maybe do you want to go over the this accrual rate so far and the current status of the trial?
Yeah, so we're a little bit behind on the screening. However, we are, catching up because the accrual have been, getting into like 3 to 4 participants per month, which is the goal. I think, one of the things we were talking about, if we include also FNA together with the biopsy, but I think it's just meeting the expectations as far as the accrual.
That's great. And then the last thing is just to again acknowledge, all of the people who've contributed to this. So we're very grateful to the folks in my lab who did the early preclinical work around Schleffen-11, especially Dr. Allison Stewart, who was the first author on that paper, and then our collaborators within our group, including Dr. Gay and Dr. Wang, who's been really done an incredible job getting this moved over from a research assay into the CLIA lab, as well as Ignacio Wistuba. And then the PIs, Dr. Krim, Dr. Reckhamp, and again, Dr. Gay on the translational side, and appreciate all the help from Dr. Kelly and the whole SWOG team that have really helped make this possible. With that, happy to take any questions.
Thank you, Dr. Byers. That was an outstanding presentation. And this really serves as, I think, the prototype of trials that we want to do in SWOG, where we take science from our investigators, such as Dr. Byers, and be able to work together to translate this into what I think is a really very exciting clinical trial. And small cell lung cancer is an area that we continue to need to move forward. So I want to thank Dr. Byers for all the work that she's doing in this challenging disease, and thank the entire team here. I think we might have time for maybe one question or so. We're a little bit behind, but Dr. Byers, let me just ask you about Schleffen-11, and what do we know about it in patients who are resistant to platinum-based therapies? What do you know about it in that setting? Of course, all of these are diagnostic samples.
Yeah, so that's a great question. We have primarily looked using that circulating tumor cell assay that I mentioned that we had developed, and we've presented a little bit of data from some of the initial work on that at World Lung. But what we do see is that Schleffen-11 frequently decreases in patients that have been receiving treatment with DNA damaging agents or have relapsed following one of those treatments. And so I think that's one of the reasons that this study, and using the PARP inhibitor early in treatment instead of waiting till relapse, I'm hopeful that that is going to provide something that's more active compared to waiting to later lines. Mm-hmm. And the other thing, the preclinical data also really suggests that Schleffen small cell lung cancers may be more sensitive to chemotherapy. And so I was mentioning that if you look across, an all-comers population, about 50% of patients express it. So far in our screening, about 2 out of 3 patients have been positive. And I think it may be that patients that are, because patients are on treatment, maybe the patients that are having some response, doing better, PS is kind of staying good or getting better, may be the patients that are more likely to get screened, which is not necessarily a bad thing. If we're finding more of these, biomarker positive patients faster, it may help with accrual, but that may be why we see a little bit of a bias in terms of more positive cases coming through with the screening.
Well, I think it's just exciting that we now have these 4 subtypes, and we can leverage that. And, we can maybe start thinking about precision therapies for small cell lung cancer. So I'm just going to leave it at that. And again, thank you so much for an outstanding presentation. We are a little bit behind, so we're going to move forward now to Nagla. I apologize, skip your slides because you already went through them. Thank you so much, Nagla, as well. She's done a great job on this trial and moving it along too. We're going to go to Dr. Hesketh, who is our chair of our Community Engagement Subcommittee. Dr. Hesketh.
Thank you, Karen, and I think I'll be able to make up some time because my comments will be relatively brief. But hello, everybody, and just wanted to give you a quick update on what's happening with our community engagement subcommittee. Next slide. So again, we have a small but very dedicated committee. These are the folks that are involved. You've already heard from Judy earlier, and she's been a tremendous patient advocate who's very, very involved with our group. And recently we've had a new SWOG staff support member, Chrissy Laubach, who also has been terrific. Next slide. So this really was an idea that I think Karen, I need to give credit to, came up with. Basically, we started about 3 years ago, and I think really the idea was to try to see if we could further the mission of the Lung Committee by just trying to engage more actively our community-based oncology folks. And so I think our responsibilities and our charge is basically to try to provide input during the clinical trial development process, to review the trial designs, to particularly see if they are meeting community expectations. Very importantly, are there going to be potential barriers to successful trial execution? And then really serve as champion for the trials in the community network. We have monthly calls of our subcommittee, and at some point, Karen, we hopefully will have in-person meetings again, and we'll all be able to get together. And, let's hope that the fall will be our next get-together. And we participate in a number of accrual enhancement efforts. Next slide. So basically, during protocol development, one of our subcommittee members is assigned each new protocol once it's been approved by the Lung Committee, and we're involved in every step of protocol development, including submission to SWOG triage, submission to CTEP, the protocol development process activation, and then post-activation, we stay involved in terms of the accrual enhancement types of activities that are being conducted with the active studies. And you can see the current assignments. So that's okay, great. Next slide.
Sorry.
No problem. So in terms of ongoing or new initiatives, we are reaching out to all of the NCORE sites right now. We're really working in partnership with the MedNet. Nadine Husri, one of the co-founders of the MedNet, is a member of our committee now and is very actively involved. And basically, I think many of you are probably familiar with the MedNet. Hopefully you're subscribers to it, but it's a physician-only web-based community that really serves as a way to try to provide some expert commentary on real-world questions in oncology. It's been in existence now for about 7 years. I think the number of oncologists is larger than that shown. And they actually got a SWOG Hope Foundation grant previously to try to raise awareness for 2 SWOG trials. They presented their results at NIH 2 years ago, showing that they were able to succeed. And what we're trying to do basically is to reach out to NCORE sites right now to educate them about 2 of our exciting phase 3 trials, S1914 and S1827, and basically get the NCORE site members enrolled in the MedNet, and then use the MedNet as a tool that we can try to educate a broader audience about our active trials. We're also basically going to be reaching out with digital engagement to try to develop some social media tools to enhance patient and provider education efforts. And then our most recent effort has been to launch a community oncology support group. Next slide. Next slide. Okay. So the oncology, community oncology support group is really our newest initiative. And what we're trying to do here is to get even a larger group of community oncologists to work in collaboration with our subcommittee to try to better engage community-based oncologists who are interested in lung cancer and the activities of our committee. And so what we plan to do is to try to obtain their input as well on new study concepts, provide them with focused updates when we activate a new trial, obtain feedback if we're having challenges with accrual, and then periodically try to update them on what's happening with clinical trial progress. So that group will meet quarterly, the 3rd Thursday of every month. And again, they are invited to participate in the in-person subcommittee meetings that we have at our SWOG group meetings. So We've already enrolled about 15 very interested community oncologists in this particular program. They had to respond affirmatively to an invitation and indicate that they really were interested in this. And we hope that that'll be just the start of getting a larger group of community-based oncologists involved in this activity. So that's my last slide, Karen. I think I have one slide that shows my email address. Anyone that is in the audience now that has interest, that is community-based, that wants to participate potentially in this group that I just showed, please just email me and I would be happy to reach out to you. That's my last slide, Karen.
Thank you, Paul. And I just want to say thank you to your leadership and to your committee members. And you all are doing outstanding work. And I'm so excited and proud of this committee for everything that you all are doing. As I said, you know, we're all a team, every one of us, community, academic, all of us, we're all a team. And as you can see already, we've got great trials, and having everyone's input is what makes them really the best trials. So appreciate all that you do. All right, now we are on the home stretch, and that is looking at the thoracic oncology trials in early stage 4 disease. So having said that, we do have one additional presentation that Krishna Ganchuro asked me to give her an opportunity to present this trial. This is an observational trial, so I will ask her to run through these slides again. I know we focus on therapeutics, but there are definitely other important trials that need to be done, and here is one of those. So.
Thank you very much, Dr. Kelly. So this is iCheckIt, which is immune checkpoint inhibitor toxicity S2013 from symptom control and quality of life. So this is a prospective observational study. As a lung cancer oncologist who is treating lung cancer, we use these immune checkpoint inhibitors all the time, and it used to be mostly in metastatic setting or advanced setting. Now we're using it more and more in the adjuvant and also pretty soon in the neoadjuvant setting too. So we can go to the next, yeah. So how would we balance the both the survival and also quality of life and for our patients? So if we can come up with the risk prediction model, who would develop these immune-related adverse events for patients receiving immune checkpoint inhibitors in solid tumors? That would help for our patients and our clinicians to give them for people who would be able to tolerate and also to monitor closely. Next slide, please. In case if they develop side effects. So the primary objective of this study is to develop and also to validate in the same study a risk prediction model for non-hematological grade 3 or higher IRAEs in patients receiving immune checkpoint inhibitors in solid tumors. So next one, please. The secondary objectives, as we see more and more, many of these people, they have grade 1 or 2 toxicities, for example, endocrinopathies for which they are on treatments for the rest of their life, or having skin rashes which affect their quality of life. So our secondary objectives over the 12 months of receiving these immune checkpoint inhibitors is looking at the incidence of any grade non-hematological and grade 4 hematological IRAEs. We're also looking at patient-reported quality of life and PRO-CTCAE, along with the toxicity over time, which is focused on the chronic grade 1 and grade 2 toxicities. We also plan to look at the tracking patterns and treatment of IRAEs and toxicity resolution. So with the translational objectives, our plan in this study, which is planning to enroll 2,000 patients, is to look at the cytox score. By measuring 11 different cytokine levels, patients will get 2 blood draws, one prior to initiation of immune checkpoint inhibitors and the second after the first cycle, to predict the development of IRAEs. So there is another blood draw, which would be at the time of grade 3 or higher IRAEs too. So this will be a huge biorepository for archival tissue and serum for predictive and prognostic IRAE risk for anyone who is interested. in the study. So this would be a dream come true for any investigators. So if you don't remember anything from this secondary objectives, I want you to remember what we're looking at is chronic toxicities and patient-reported outcomes. Next slide, please. Eligibility is pretty wide. Friends of ASCO would be very happy with this eligibility criteria because this is for anyone receiving ICI as standard monotherapy or combination. This is not with the chemo or bio or targeted therapy. We intentionally kept it so that data will be homogeneous to predict the score. And they can have prior ICI therapy, but must not have discontinued ICI for IRAEs. And they should have recovered from the side effects of prior therapy, as we outlined in the protocol, and able to complete the PROs either in English, Spanish, or French. Next slide, please. As I mentioned earlier, we're taking these factors for the risk prediction model. So in this 2000, Dr. Unger and the statistics team came up with this two-step statistical analysis where we initially take 1,200 patients and look at these factors, both demographics and history, which includes age, sex, race, performance status, BMI, along with autoimmune history of the autoimmune problems or immune checkpoint inhibitors or other treatments, along with the patient-reported outcomes at baseline, because this is a baseline prediction tool, including labs. Then after the first step, we get all that data, and in the next 800 patients, we will validate the data. You can go to the next slide, Dr. Kelly. So our accrual goal is 2,062 patients, and this is approved and will be open to accrual in early summer. So I'm hoping as a lung committee, we use most of the immune checkpoint inhibitors along with the melanoma and renal cell. And I'm hoping we would be able to enroll, and it would be easy to enroll because there are only 5 evaluation times at baseline, week 4, 12, 24, and 52.
All right, thank you so much.
Thank you.
We'll look forward to it. Okay, so Dr. Chang, do you want to say a few words about Insignia?
Yes, thanks. So I hope you are all thinking about Insignia for your frontline PD-L1 positive patients. We're about 1/3 of the way through accrual. I think the ECOG actually has been doing better than SWOG, so hopefully our competitive spirit will kick in. You know, I think there are a couple of things to make this easier for patients, some clarifications to make it easier to accrue. So to be clear, there is a biomarker component to this trial. We're very interested in tissue. However, you can accrue even if you don't have you know, the 20 slides. So whatever you have, we'll take. With regard to brain mets, so you are able to, if your brain mets are treated, you need to have a study that shows stability, but that can be within 2 weeks. So a head CT within 2 weeks, that would be all right, or asymptomatic brain mets. So those are some of the questions that have come up. Finally, I think that, you know, when we first started this trial, there was a lot of controversy around the 1 to 49% group. And, you know, I think that with COVID, one of the things that we found is that many of us around the country have treated with IO and dropped chemo in the in the standard of care or off protocol setting. I certainly have had patients with in the 1 to 49% group on single agent Pembro who have done really, really nicely. So I think that was a question beforehand and a comfort level. And I think that many of us feel much more comfortable with that piece of accruing. So again, please think of this trial. We're trying to, we are back up to, as everybody did, took a break or a pause with COVID. Many accruals went down, but now we're back up. And please think of this trial up front. It It is designed to answer really important questions such as the sequencing of chemotherapy, if you can start out with single agent IO, and if you add chemo to IO post-progression, does that work as well? So really important questions. And there's a question in the chat, do you take patients with FNA samples? And the answer would be yes. So we're taking any tissue you can give us. Obviously, we would like to have a prognostic signature for IO and a predictive signature of chemo plus IO. So we want to have more tissue, but definitely you can go ahead and email me or Hasborg or us both about any issues you have with tissue. And right now, FNA is okay. FNA of bone is likely okay as well. So just email me if you have questions. Thanks. Bye.
Thanks, Anne. All right. Dr. Goldberg is our study champion for the next trial. Sarah?
Hi, everyone. So this is an ECOG trial that I know some SWOG sites have open, and I think is a great trial to consider for your EGFR patients. So just wanted to tell you about it. It's a phase 3 trial of osimertinib plus bevacizumab versus OC alone as first-line treatment for metastatic EGFR mutant non-small cell lung cancer. Helena Yu is the study chair, and I'm championing it for SWOG. So Karen, you could just go, we could probably just skip over this. I think people know the background, and we can just go to the schema, and I can tell you a little bit more about it. So again, this is for untreated metastatic EGFR positive lung cancer. Patients, just very briefly for eligibility, patients are allowed to have brain metastases. Any sensitizing EGFR mutation is allowed, and performance status of 0 to 2 is allowed as well. So patients are randomized 1-to-1 to the single agent OC, which of course is now the standard of care, versus OC plus Bev at our typical doses of Bev every 3 weeks IV. The primary endpoint is progression-free survival here. And there's some really interesting, of course, clinical, but also correlative endpoints that are being looked at. The accrual goal is 300 patients. So it's a fairly large phase 3 trial. It opened just a couple of months ago, and there are a few patients on, but it's been slow so far. It's I think, a fairly easy trial for patients who have EGFR mutations to enroll to. There are some exclusion criteria based on the BAS that, again, we're all familiar with, I'm sure. But please consider opening it, if there's no competing trials in this space at your center.
Thanks, Sarah. All right, Roy, do you want to talk about LungMap?
Sure. So very briefly, we had a LungMap meeting earlier today. The active studies are in green. The selpercatinib, that actually is about to change, but that's for RET fusions. Soon it will be a trial with chemo combo. That's in second line or more. Open now, though, is the Amgen 510. Suki Pada from our group, now the lead on that. 1900E for KRAS G12C, looking at 3 different mutational groups. So that's really exciting. That's open. We have another study all the way on the right in blue, 1800D. That's going to be N803. That's an IL-15 agonist plus pembrolizumab versus supportive care, standard of care, excuse me. And that's John Rangel. And we're looking for new ideas. So screenings continued to go well over the year. We need more sub-studies. We screened so well and accrued so well that everything in blue is closed. And they're all being written up. So not a lot of time right now, but anyone that has an idea from the science at their institution, a doublet, please contact me or one of the team. And then we're going to use Foundation 1 testing now. So the idea is, a lot of our patients have already had Foundation medicine testing. So thanks to the team, Joel Neal, Mary, a few others have really been working point on this. So now if you have prior Foundation testing, and Karen's moving me along, you can actually...
It did it itself. It must be on automatic here.
No, but it's okay. But if you've had prior testing, it will be allowed. That's any day now. and that'll be very important because one, it'll be better for the patient, and two, it will save some money. And we're also working in the future to be able to allow other tests to be incorporated. That's a little bit more complicated, you can imagine, from a regulatory point of view. Okay, we can move on now, Karen.
Yeah, I don't think we need to talk about this one.
No, it'll all be in the notes and from the LungMap meeting earlier today at 1 o'clock. Next slide. I don't know that there's that many more.
This was for if Dr. Potter wanted to make a short presentation about S1900E, or she doesn't have to. Go ahead.
This is just very, very quickly, because I know we're 1 minute here. So as Dr. Herbst mentioned, this is an open study for your patients with KRAS G12C. They have to be previously treated with at least one line of therapy and without any evidence of controlled brain metastases. Then after an analysis of Foundation Medicine results, they will be assigned to one of 3 biomarker cohorts based on the presence of a mutation in P53. Second cohort, STK11, and third cohort is kind of the catch-all cohort for those with double co-mutations in STK11, P53, and also KEAP1. So it's likely when you're screening your patients for the study, if they're not eligible for cohort 1 or 2, that they should be eligible for cohort 3 as long as that cohort is open. Thank you.
Yeah, thanks. Great job. And this opened actually rather quickly. We only started talking about this about 1.5 years ago. So this is a really nice study open at all of our sites. Next slide.
So Roy, do you want to talk about this? You had mentioned it.
Right. So I don't know if, the PIs are on, but this is a redesign now. The fact that
yeah, I don't see Janelle on at the moment. So
no, I don't want to. But basically, the idea was, now the RET inhibitors are approved in the front and the second line setting, making our current trial. This happens. Science moves on. So now this is going to be a trial looking at carboplatin, pemetrexed, and selpercatinib in stage 4 recurrent patients who are found to have a RET. So you can pre-screen for these patients and find those patients. And we have a wonderful design from the Stat Center, Mary and her team. First stage, 30 patients, 12 or more responses goes to a second stage and equals 25 or more. So this is in revision right now. It's going to take another 3 to 4 months to get this forward, but we do have company buy-in and approval, and we're about to go to drug selection committee to formalize it.
And you'd already talked about this one, so.
Yeah, this one, I just refer to that paper of John Rengel, this is a very exciting drug. There aren't a lot of things that work in refractory immuno-oncology. I'm sure some of you have probably been in clinic today, and it's tough. So here we have the drug, the IL-15 agonist plus nivolumab in either immunotherapy naive patients or anti-PD-1 progressors. And
may I interrupt, Roy?
Of course.
Yeah, so this design isn't the design that we're going to be using in LungMap. Recall that LungMap is going to be looking at N803 combined with pembrolizumab, randomized against standard of care in patients who have previously received immunotherapy, pembro or some other checkpoint, PD-1 blockade, and had progression on that. And the target sample size will be 130 patients who have primary resistant disease and 300 patients who have acquired resistant disease.
Yeah, thank you. Thank you, Mary. I was just actually looking at my paper here because it didn't seem right to me either. So this must be an old slide.
Happy to have the new one.
Okay.
All right. Thank you, Robert. We'll change that out. And okay. So we do have one study from ECOG that Dr. Mazzarelli is the study champion on, and this is a good study as well in terms of as we get geared up again with LungMap, we want to support this trial too. So Dr. Mazzarelli, do you want to talk about this? Thank you so much.
Thank you. So this is a phase 2 randomized trial of cabozantinib versus cabozantinib plus nivolumab versus standard chemotherapy for non-small cell lung cancer. So this is advanced non-small cell lung cancer with prior at least actually one line of progression of chemotherapy and one line of anti-PD-1, PD-L1, and they will be randomized, stratified according to the duration of prior immunotherapy, less than 6 months versus equal or more than 6 months. And so basically there are three arms. Arm A is cabozantinib at 60 milligram PO daily. And then there is the combination arm cabozantinib plus nivolumab, where cabozantinib is going to be 40 milligram daily and nivolumab 480 milligram IV every 4 weeks. And then the standard chemotherapy, which would be either docetaxel plus or minus ramucirumab or gemcitabine or paclitaxel according to the clinician preference. Now, there was a specific 25 patient cohort, Arm T, which would be cabozantinib or nivolumab for patients who have met exon 14 mutation or ROS1 or RET. However, there is currently an amendment, and most likely this cohort will go away. So please ask me any questions if you have a possibility of randomization, of inclusion of these patients. I'll be happy to answer.
Yeah,
thank you.
Thank you so much. I do think that this is a good trial too. And then finally, I don't know whether Ann Sao is on, but
Anne texted me to let me know that she had to go see a patient, and she was just hoping to report that, yeah, we have 11 out of the 66 planned patients enrolled, likely one that's being screened within her institution, and a lot of questions and interest in the study, and anecdotally some really good evidence that ramucirumab is pretty active in this population, and she encourages people to think about this study if they see patients who are eligible.
Right. She mentioned this to us yesterday, and I will echo what she said because we have patients on this study too. So FYI, this is a good study. We know that it is thymic carcinoma, but we have 11 patients on. We've kind of been on a pause. So it's, things cycle. So hopefully we'll get more patients on. But this truly is a good study. It's going to be the only study conducted. Here again, we need to make progress in these diseases, albeit they are rare, and we have patients, and the patients certainly appreciate it. I can tell you that for sure. My patients are all very lovely. So with that, I want to thank everyone. I apologize. This is a whirlwind. It's not our typical 3-hour session and hard to have a lot of chat. I apologize for that. We will go back to polling questions in the fall. Hope to see everybody in Chicago. I believe it's going to be a hybrid meeting, but I'm hoping everybody will attend the meeting. I love to see everybody in person, and just thank you for bearing with us today. I'm just so excited, as I always say when I leave these meetings. I just am so excited and so proud of the work that we are all doing together as a team in SWOG and across the NCTN. I really appreciate our SWOG champions, and I want to echo that we really, I think SWOG does a great job of being a team player and working well with the other groups, and we appreciate that and they help us out as well. So thank you all. Look forward to seeing you in person in the fall. And if you have any questions, I really cannot emphasize this enough. Please email me or the PIs. We really do need to accrue. We're a little behind on our accruals. So just urge everyone, if you're having problems, let us know. We may need to make some amendments. We're happy to do that, but we can't do that unless we hear from all of you. Particularly, we need to know that there's something that's consistently being a problem. We're happy to make amendments. Unfortunately, we try to make trials perfect, but I haven't gotten a perfect one yet. But certainly we always work on that. So be safe. Thank you all. Enjoy the rest of the SWOG meeting. I think it's been fantastic, even though it has been virtual. Looking forward to the plenary session tomorrow. Had a great plenary today, and just great to be a part of the SWOG. Thank you again.